Well, next I'd like to welcome David Bussue, who can talk to us about some of the realities of providing support services in the city of Sheffield and his experience and perspective on these questions. David, I saw your website recently for your organisation. I was very pleased to see how clearly and well you'd set up the sections on self-directed support. So just from my perspective, kudos to you.
Thanks, Simon. Thank you. Hi, everyone. I'm really interested in what's been said so far, and particularly want to comment later on around neighbourhoods, the benefits of them, but also the risks that a neighbourhood model can deliver in terms of exclusion of particular communities, and also some more conversation around direct payments. But anyway, so we're looking at the new and progressive vision for social care in later life. For those who don't know me, my name's David Bussue, and I'm Service Director at SACMHA Health Social Care, which began its life as Sheffield African Caribbean Mental Health Association, but now is an adult social care provider working across all of adult social care. It's a tough time to be active in the adult social care space, and it's a tough time to work in this space, tasked with addressing the challenges we all face as we age and as later life becomes our lived experience. My father, who will be 98 in November, often states, especially when he's in need of support to do something that he previously did without any thought, an old, I think, Caribbean saying, once a man, twice a child. Somebody will correct me if it came from somewhere else. But their sentiment is true. It's tough to be active in this space when you have a focus on home care support, that most vital of supports that has the stated aim of keeping most people in their homes for as long as possible. Adult social care, and particularly domiciliary and residential care for seniors, are probably two of the most heavily regulated and prescribed services in the area of what was called the personal social services. Allied to this, the reward, the remuneration for the staff employed in this area creates some of the lowest paid jobs. I think this notion of unskilled workers in such a regulated industry is beyond me. There are rightly increased and increasing demands with regard to the quality of this provision, but the financial investment from government is woefully inadequate. The fragmented nature of social care for older people means that the challenges of consistency of care and the notion of continuous improvement are notoriously difficult to achieve when we're dealing with hundreds locally and thousands nationally of individual businesses and organisations and charities, all tasked with keeping our elders safe and comfortable and with the ability to still enjoy life. So in this brief presentation, I thought about what I would do, and I was keen to bring alive some of the impacts of the challenges that I've outlined and how they're experienced by individual members of our community who are recipients of adult social care services. And I thought the best way that I could do this would be to share some stories. If I could have the first slide, please, Natalie. No, that's the second slide for the first one, Mr. Gray. That's the one. This may not be what you're expecting, but I think the lived experience speaks volumes. Ernest Gray, or Neddy as he was affectionately called, came to the UK from Jamaica as part of the Windrush generation. He was married to Rosalind for over 60 years, and they had 7 children plus grandchildren and great-grandchildren. Mr. and Mrs. Gray were seldom seen apart, and they shared a deep and enduring love. The impact of Mrs. Gray's death on Mr. Gray about 18 months before he passed can't be overstated. Mr. Gray died in April 2019, and in his later life, he lived with dementia and other illnesses of old age, illnesses that required him to receive care and support to meet his needs and to support his children as they sought to care for him. Mr. Gray was a plasterer by trade, but in truth, he could turn his hand to pretty much anything, to pretty much any task, and make an excellent job of it. He was a quiet man, a man of few words. I know we don't, this is the language you use now, a term I'm going to share in a moment, and I hope it's taken in the way that I mean it when I say that Mr. Gray was a man's man. I know that's not a term we use now, but I struggle with a different description of him. He was a man of few words, but when he spoke, there was a depth and a wisdom to what he said. He was actively involved with his church, as were most of his family. He sang in his church choir, and he had a beautiful, beautiful tenor voice. He always looked sharp, as I think the pictures demonstrate. He took care over how he looked. He was always smart, and his family ensured that this continued even when they had to take pretty much full responsibility for what he wore and when. There were a number of care providers that supported the family, and in truth, it was a challenge. It was a challenge. It was a challenge for the paid carers, and it was a challenge for the family who wanted carers to care as if they weren't being paid for their support. A difficult circle to square, particularly in light of the things that have already been said about reward for this kind of work. Mr. Gray's youngest daughter shared with me the distress that the family faced when it became clear that this particular provider, I'm not going to name names, this is not what this is about, but this particular provider, when dealing with Mr. Gray, simply never spoke to him. Let that just sink in. They never spoke to him. Imagine the situation. Someone is undertaking some of the most intimate and personal aspects of your care, and they simply don't speak to you. You are naked in front of these people, or more than one person, and they simply don't speak to you. You're reliant on this person or these people to be nourished and to be hydrated, and they simply don't speak to you. When the family became aware that this was happening and they raised it with the care staff, the response slayed them. I hope you will find it as shocking as I do. The reason why the carers said they didn't speak to Mr. Gray as they provided his care, and I use the term care loosely, was that he had an accent. He had a Jamaican accent. Just let that sink in. Mr. Gray, who had come to the UK from the Caribbean to help rebuild the UK after the Second World War, and had to navigate his way around Yorkshire accents and Irish accents and Scottish accents. At the end of his life, when he needed care, that care was offered without the semblance of actual care. Can I have the next slide, please? Muriel Bussue is my mother. She came to the UK from the beautiful island of St. Kitts and Nevis in 1957 with my two eldest siblings to be reunited with her husband, my father, who came to the UK in 1955. They had 4 more children here in the UK, and when my youngest sister, Angela, started full-time school, Mum gave up her role as a nursing auxiliary, as they were called in those days, I guess a support worker or healthcare assistant in today's terms, and went to Lodgemore Hospital here in Sheffield and began her nurse training. There began a nursing career of some 40 or so years in the NHS, and then a further 10 or 15 years in the private sector after she took early retirement from the NHS. With the exception of her period of training, Mum always worked in what were then called geriatric services, ending her NHS career at St. George's Hospital here in Sheffield, which in those days was called the geriatric hospital for the city. Mum was always active. She was always involved in something. She was an amazing cook, a skilled seamstress. She was active in her church, and she was also a singer like Mr. Gray with a beautiful alto voice. In fact, when I was a child, we used to sing together. Mum was a community person. She collected money and she collected food for the miners during the miners' strike in the 80s. And she ran a lunch club for the old people at her church, as she called them, though many who attended the lunch club she ran were younger than her. She was a member of the first Health Watch patient partnership group in Sheffield, and after ending her career in nursing, retrained as an adult literacy tutor teaching English and sewing. In 2009, Mum was diagnosed with a malignant tumour on her liver, but against all odds, she survived. However, she was never quite the same and never really able to do the things she used to do, and increasingly, she needed support at home. My dad is very protective of his mum, his wife, as he calls her. I often have to remind him that his wife is my mother. And he struggled to accept people coming into their home, though he accepted that this was needed to support him and to support us as we cared for mum and to keep her safe. In 2012, our mum was diagnosed with Alzheimer's and a steady decline began. Again, a number of care agencies were identified to provide support to us as a family. The support provided was of varying quality and varying reliability. I began to learn, I'm a social worker by training, I'm still a registered social worker and practice educator, but I learned the impact of the term time and task. One of the things my father in particular struggled with, though, was the frequent changes in carer. But you know what really grated on him? It was something that really, it was more of a challenge than the unreliability and the varying care. It was usually when some very young carer would appear, often completely unknown to the family, and announce, "Hello, Neville, I'm here to care for Muriel." Now, that might not sound like much of an issue, but let me assure you, in the Caribbean community, little young things, as my parents called them, they simply did not address seniors or big people, as my dad called it, by their first name. Indeed, to do so was a sign of a total lack of respect. My parents were and are proud people, contributing people. As the community developed in Sheffield, they were go-to people for the Caribbean community for many years, and now they were left feeling as if there was a complete breakdown in respect. So why have I shared these stories in an event like this? Well, you'll have heard me use two words in telling these stories: care and respect. And the Accountable Care Partnership in this area, in its 10-year vision, states our partnership vision is for our health and care services to be integrated, joined up, seamless, to reduce and to remove inequalities in health outcomes and access to support by playing our full role as anchor organisations in our city. And to do all this in a way that involves people, their experiences, and our communities at the centre of our work. To do all this in a way that involves people, their experiences, and our communities at the centre of our work. Well, I'd like to add that they need to add two other words to this ambition, a vision that I support, and those words are care and respect. To do all that they're aiming to do, but to do it with care and respect. The situation I shared in telling the stories, there weren't safeguarding issues. Nobody was physically hurt or endangered, but that lack of care, that lack of respect in just two incidents that I shared. And I wish I could say that they were the only two incidents, but they weren't. Highlights the challenge that we all face in this space as we work to achieve a new and progressive vision for social care in later life. The simple application of some of the most basic tenets of person-centered care would have rendered the situations I shared impossible. With Mr. Gray, I'm sorry, I didn't quite get that, Mr. Gray. Could you say it again for me, please? With my mum, hi, I'm here to care for Mrs. Bussue. Hello, Mrs. Bussue, my name's Lisa. How do you like to be called? What do you like to be called? Simple stuff, basic stuff. My challenge to the system and to us in the VCF is how do we make this vision? How do we make this vision that I've shared real and meaningful? How do we deliver a partnership vision for our health and care services that is integrated, that removes inequalities in a way that involves people, their experiences, and do all of this with care and respect? Can I suggest that a great starting place would be to add in, to embed, to set in the DNA of provider organisations, all organisations, real care and real respect. Thank you, and I look forward to contributing to the conversation later.
Thanks, David. That was incredibly powerful and helpful. Thank you.